morning, wherever you're tuned in around the country and our various streaming platforms, and also to our audiences on KTN, into a health conversation this hour as we get into it. Not necessarily health in terms of how you're doing, but health in the mechanics and how it will be, practiced in this country. With a lot of hullabaloo over the last, 6 months, and maybe easily a year before that, when it looked at the introduction of a new health system. And this morning, we're going to be talking about understanding the difference between what NHIF, which is phasing out, and SHA, otherwise known as SHA, which is what is coming in. Dr. Abdi Mohammed is the director of the Social Health Authority, which is what SHA is, and he's in the studio this morning to help us through with that conversation. Dr. good morning.
Good morning. Thank you.
Karibu sana.
Asante sana.
Okay. Yeah. Big monkeys on your shoulders. We are going to start there and just make that disclaimer. But before we heat up the hot seats even more with some of these questions that we have and some of these discussions around exactly what SHA is going to do, let's welcome you. Kind of akin to the frog in the Bunsen burner, in the thing that the beaker that gets warmer and warmer over time and not quite sure what's going on, but all right. CT has proverbs this week from Côte d'Ivoire. And so maybe you can listen to that proverb and tell us what you think about it and how you would interpret it.
Right. When the eyes cry, the nose does not rejoice.
Interesting. It means when one of us is in trouble, the rest of us can't be happy. We can't rejoice in the suffering of the others. And I would tie it to the Social Health Authority so that a burden shared is less than when you face it alone.
Good point.
A problem shared is half solved.
Half solved.
Voila. Okay. So, we're getting into this whole Social Health Authority conversation this morning, Dr.
Yes.
And so yours is to help us understand exactly what's going on. We've had several conversations trying to break this all down and understand what is going to happen. NHIF, for the longest time, has been the fund that most Kenyans know that when I'm going to hospital, even as it develops, I'm going to start out by having my NHIF card. I can go to hospital, certain expenses that would be needed for my healthcare then are taken care of by virtue of the fact that I have an NHIF card. And having an NHIF card also meant that there was a certain amount of money that I paid every month or that I contributed every month to this fund. So then I go in later and I'm able to cash in on that contribution and I can get taken care of. Whether it's medicine that I need off the jump or if I need to be admitted for whatever, NHIF steps in and takes care of that. Right? We've also seen over time that NHIF had its own issues here and there, whether there was mismanagement, whether we didn't have enough people on the grid over and over again. In 2022, 2023, we started to see this major shift then from NHIF and now to the authority which you lead. We want to understand the transition and how all of this is going to happen in real time and in practicality. Dr. Let's start there.
Thank you. I hope when you said lead, you meant as a board member.
Yes.
Because
yes.
I'm not in the management.
Yeah.
But if you look at what has happened over the last 1 year, as you say, it is trying to address the whole health system. Rather than doing piecemeal changes here, piecemeal here, this is meant to address the whole ecosystem by having the laws to anchor to begin with, and then now putting in the requisite people in terms of the people and the systems to address. So there were 4 laws that were passed, which the president assented to on 19th October 2023. There was the FIF, there was the digital health, there was the primary health care, and there was the social health insurance. So when you look at each and every law and what it's trying to do is to address some of the challenges that we face as a country and the health sector has faced over time. There is a fifth one, which hopefully will come when the time comes, which is the quality authority, which is supposed to address the quality of services that we get at health facilities. So the FIF, if you look at starting with the one which doesn't have any court case, is supposed to address.
Yeah, let's start with that one.
Yes, because that's the only one that wasn't taken. There were 4 laws that were passed, but unfortunately, the petitioner went for 3 and left 1. So the FIF is meant to address the challenges our health facilities were facing. Prior to devolution, health facility management and the MedSubs were able to, or the leaders in those facilities, used to keep the money that they collect and utilize for the services that they offer. But since the devolution came in, some counties have been taking away the money the hospitals collect and then put it in the main budget and redistribute it for whatever else that's required, whether it's to build a road, whether it's to build something else. And that was a challenge because you will find many facilities had difficulties in sustaining because what they were getting from the county wasn't enough. So the little they were collecting was meant to supplement. So for now, that law addresses that issue and it ring-fences that money to the facility. So that way, each facility will keep its money and will be able to utilize, whether it means hiring people to do cleaning, whether it means buying extra medicine from KEMSA because what the county has allocated is not enough, whether it means hiring even nurses, whether it means hiring doctors, like Nakuru PGH did with the previous governor when he was around. So they were able to employ doctors and nurses and employ many other things because the county allowed them to keep their money.
Sorry,
so that
Dr.
model, yes.
How was that before? What was the mode of operation before so that we can understand now?
So prior to devolution, it was what the law now says, keep the money at the facility. But after the devolution, so some counties have allowed 100%. Some said 50% return to the county. Some said 30% return. Others said 100% comes to the county, and the county now decides what to do. So you have many mismatches across the country. Some counties have agreed and are implementing. Others are not implementing. So this now does for everyone uniform, so that all counties are now required to keep the money that the facilities collect at the facility. So that way, that facility has the capacity with the health management committees to plan and budget for that money that they collect.
Okay.
So the second law that was passed was the primary health care. Now, the primary health care is the one that has the community health promoters. Prior to this law, community health promoters were being employed or hired by different counties for different things, and some by NGOs. So you will find an NGO has paid for 20, 30 community health promoters in one sub-county or in one location. And what are they doing? They are collecting a vertical program. So if it's HIV, they're doing HIV follow-up and such. If it's TB, they're doing TB. Someone else is doing nutrition, they're doing that. So what has the government done is, in that law, it has hired 100,000 community health promoters.
Yes.
I think more than 100,000 across the 47 counties in every location and in every village. So for that now, and they do integrated services. So they don't go and look at TB only, but they look at the general health of that individual or that household from A to Z. So that way, they are able to integrate all the issues a person has, not coming and asking TB, how is it? But the person may be suffering from something else that they need to be addressed. And then you walk away because that's what you have been paid for to do. And that is your job description and output. And of course, some of them were doing on those booklets. Some were using their digital health systems. Some they were using what the NGO has given them to fill in. But for now we have a national ECHIS, Electronic Community Health Information System, which now connects all of them. And each one was given a mobile phone to be able to do that work. And a backpack. I think we have seen when they were released. So what's the second thing that primary healthcare bill is supposed to address? It's also supposed to address the issue of the primary healthcare facilities, level 2 and 3. So that when we are not feeling well, we move away from people just walking to the highest facility, level 6. But instead, we now start engaging level 2 and 3. So that was the idea of that bill. And community health promoters have started working. Some counties have already implemented because the stipend comes from both national government and county government. Some are still not yet fully operationalized. Then there is the Digital Health Agency. This is now a new agency that has been created. Over the many years since independence, we have had health records being on a piece of paper, on forms, on books, on registers. Never, ever have we tried to digitize all these records and have them in one place. If you ask anyone who has gone through Kenyatta as a registrar doing masters, when they are doing for their final thesis and they need to do some research, you will see the agony when they are taken to the records section. A whole almost go down of files. Now trying to do your thesis to see what are the conditions, going through each file was very difficult, painstaking. So with this digital health agency and with the health information exchange, every hospital is supposed to have a health information system, which means you are able to record the patient's details, their clinical, your history taking and physical examination, what medicine you have given, what lab test. All that now will sit at the facility, but there is a certain part of it which will come to the health exchange, a summary. So when tomorrow you walk to another facility, I don't need to start asking you, what were you suffering from? Where were you last seen? What medication were you given? I'm able to see.
And this is around the country? So
around the country.
If you're in Mombasa today and then you go to Kakamega tomorrow with a health issue, because of the integrated system, we're going to be able to see then that, you know, you saw me last month for 1, 2, 3, this is a follow-up, and you know the information.
I will even take it further. If you are in Ramu, in Mandera, and then you end up in Kwale for holiday, Lunga Lunga, that person should be able to see from the digital the superhighway, the HIE.
And is this something that's being done now, or is this futuristic?
No, it's something that's being done. What's going to happen is no one is forcing anyone to change their health information system. So all you do is you integrate your health information. Keep whatever you have if you are private sector. If you are a county that has progressed, like, for example, Muranga, which have decided to digitize, whatever system that they have. So this is like a superhighway where you are just connecting. Keep your health information, your HMIS system, even if you are private sector, but you just connect. And there's a certain record summary that will come to this system, which now becomes available for everyone. But what else does it do? We will move away from the issue of trying to figure out or doing the KDHS, the Kenya Demographic Health Survey, trying to figure out how many mothers attend ANC clinic 4 times. How many, and that thing has been done every 10 years. So you can imagine the data that you are getting and referring to 10 years later, trying to say in this location, family planning uptake is 70%.
Yeah.
The system that you speak of,
Yes.
when was it inaugurated?
It hasn't been inaugurated.
Okay, when do we hope to inaugurate it?
It from beginning of October.
What it promises is definitely good,
Yes.
because it means that it doesn't matter where I go in the country, whatever my health data is, it will be available and it will make it for easy access to healthcare for myself. However,
yes. I knew that was coming.
is it something that we are going to put into play, or are we going to have a pilot where we
No pilot. No pilot.
Why?
No pilot. Because we have tried many pilots and we have done 1,001 pilots and nothing is working. We have done NHIF pilot with 4 counties. It did not work. After 1 year, we abandoned. We have tried to pilot something else. It's not working. So for this one, what's going to happen is it will not start perfect.
Well, nothing new ever starts perfectly.
Thank you.
That's why we have a pilot.
So
you want to mitigate against things. A pilot, even if it doesn't work, gives you information. And even if it doesn't work, that's even better, because you now know what not to do because you've had the pilot.
So the pilot, as it is, unless you mean, are you testing? Is there a testing that's ongoing? Yes. That's what I mean.
Daktari.
Unless you mean we don't start until we pilot and look
No.
at...
You
Okay.
cannot pilot throughout all the counties.
Okay.
No.
Okay.
You will random sample a few counties.
Yes.
Essentially will be considered representative.
No. That's that. In terms of testing, that's happening.
Yes.
That's ongoing.
Yes.
So that you have different counties, a private facility,
Yes.
trying to connect to see does it work.
Yes.
Is this information being sent
Yes.
the way you imagine it would? That's happening. That's
But then
ongoing.
there's something else also.
Yes.
When we talk about digitalizing
Yes.
health information
Yes.
within the counties, are we therefore saying that we actually have personnel who are trained and understand exactly what to do, so that when you have data in the system, it's reliable data?
Yes, because counties are working in conjunction with the digital health agents to train the health records officers, the different groups of people who will utilize. So the training is something that will go on. It's not something that we will say we have started and we are stopping. So it will be a continuous process, and it will be for every individual who is required to handle that.
Okay.
Yes.
The thing about then inaugurating us, because essentially what we're looking at now is SHA, and you'll permit us to just go with that acronym, is that there are certain benefits that will then be able to be seen and used by Kenyans over and above that which NHIF had offered previously.
Yes.
And you say it will be inaugurated in October.
Yes.
Right? And we'll look into some of those benefits. I'd like us to look at some of those in terms of what they are. But we're also saying that we're not going to take the time to say, okay, let's run this and see that it goes properly from end to end. How are you going to then be able to achieve a close to seamless operation if you're not doing that? Are we saying that you're going to consolidate all the information that you've used? Because yes, UHC was tested, Isiolo, Nyeri, Kisumu and Machakos, I believe, if it was not Makueni.
Yes,
so you have all that Machakos. You have all that information. You've seen what's wrong. One of the things that we heard over and over again is that there's certain amenities which were not available from county to county. So it was difficult then to deliver UHC. So are we saying that if you don't pilot it today, because you said we did pilots, they didn't work, right? But at the same time, you want to be able to deliver health come October. and yes, you'll have teething problems, but can you do that if you're not using the requisite information that you've gathered through a pilot process?
But do remember, a pilot is like a research project, and the point you make is an extremely valid one. It doesn't matter whether it worked or it didn't work. You have information that
you should be able to
which
use.
you would not ordinarily have if you had not begun that process.
Yeah. So is it a consolidation of all that information that was gathered and to say, okay, this is what we're going to do. Come October, we feel adequately confident that it can run and run well?
So now, to address all that, that's why we have the Social Health Insurance Act, which created the Social Health Authority. And what did it do? It considered all those issues. The report from the World Bank, the reform which was launched, the pilot report which was done, NHIF as it was, to look at and say, what are the issues and how do we address them? So the issues that came up was, the first thing, if you look at, is the way the Social Health Insurance Act, or SHA, has been designed, is it has 3 funds.
Yep.
So what was the idea behind why do you have 3 funds? So NHIF, as it was just contributory. So you only benefit if you have contributed and you are a member. If you are not a member and you have not contributed, then there is nothing for you. You are outside that. But with the Social Health Insurance Act, there are 2 funds that benefit you even if you are not a contributor. If you have registered, that's enough. Just registered is enough for you to benefit. The first one is the primary health care. The primary health care fund is tax funded and it comes from Treasury. That one entitles every Kenyan to benefit from, irrespective of their contribution.
Right.
So the second one that you benefit from is emergency. If you look at emergency care, it says in the Constitution it's your right. And I think Article 43, but it also says under the Health Act 2017, still it's your right. But there has never been any way of operationalizing that. Because always the challenge has been, who funds it? Where is the fund domicile? Is it at the Ministry of Health? Is it at NHIF? Is it at KMPDC? Who holds it and who is accountable for it? But for the first time now, we have that being available to everyone at the Social Health Authority.
Okay. Let's take a break at this point. It's 28 minutes to 9 a.m. We want to look specifically now at the Social Health Authority and what then benefits that people be by virtue of the fact that you have a card and that you're a fully paid up member at the 2.75% of your gross net income, that whole, issue. What then will I be able to have when I walk into a health facility at whatever level, based on the 3 funds that you spoke about? What can I get? Will I walk into hospital with my card, get treated, walk out without an issue? And if I must sleep in hospital for 3 nights, will somebody be telling me to pay another 20,000 shillings? We'll look at some of those when we come back after this break. Let's take a quick look at weather and traffic. Looking at the benefits of SHA this morning. We'll be back after this.